Al-Saffar and be moderating tonight's session. So I'll just share. Is it visible to you?
Yes, dear,
Yes.
it's visible.
Yes. So welcome to of Module 5 of Capacity Building in Medical Education course presented by Medical Education Committee 2024 by the RCP London Iraq Network. This program was designed to enhance the skills and knowledge of medical educators in 4 Iraqi medical colleges, Wasat, Al-Amid, Al-Kafil, and Suleimani. The aim was to establish a TOT group of medical education in 4 medical colleges. Target audience is faculty members from 4 medical colleges as seniors, juniors, and medical students interested in medical education. This course was presented through the platform Moodle with all its materials, the quizzes, the assignments, and the discussion forums. Module 5 is entitled Monitoring, Evaluation, and Feedback. The learning objective of this module is to apply the monitoring and evaluation methodologies in medical education to ensure the quality and effectiveness of teaching programs and to facilitate continuous improvement in the training healthcare professionals. The course consists of 6 modules. We reached module 5, and in order to obtain your certificate, you have at least to attend 5 of 6 modules, participate in pre and post-test evaluation, participate in discussion forums, and complete the required assignments. Today's speaker will be Dr. Naila Kamal, a senior lecturer at Imperial College School of Medicine, London. She is a fellow of obstetricians and gynecologists 2016, has a certificate in advanced structured learning and teaching from Imperial College London 2008, Masters in Medical Education 2009, Imperial College London, a Fellow of Higher Education 2009, Higher Education Board UK, a certificate in Safety, Quality, Informatics, and Leadership 2016, Harvard Medical School, a board certified in Telehealth 2020, American Board in Telehealth. She has over 32 years of clinical experience in the United Kingdom's National Health Service, NHS, and 16 years of affiliation with Imperial College School of Medicine, London, UK. A special interest in running gynecological cancer ambulatory diagnostic and management clinics and chairing cancer board meetings. Record in delivering higher educational targets in medical education and undergraduate and postgraduate levels, including innovative models of learning using disruptive technologies such as augmented reality and artificial intelligence, keen interest in patient safety and medical ethics. She was awarded with Distinguished Teacher Award, Imperial College London 2014, a key opinion leader, chaired high-level panels at the United Nations in 2019 and 2022, highlighting ICT's role in innovative healthcare. This is tonight's timeline, and I would like to draw your attention that the registration form will be published only during the first half an hour of tonight's meeting. And for the ground rules, you all know have to keep our mobile phone silent. We have to keep our microphone turned off. Type whatever question you have in the chat box and raise your hand when the discussion period starts to have all your question answered. Now let's enjoy this learning experience. And Dr. Naila, the stage is all yours.
Thank you so much. I'm a bit embarrassed by your run through of my CV, but thank you very much for giving me this excellent opportunity. And I'm really humbled to be considered to be worth giving this talk to all of you. So first of all, can I check you can see my slide?
Yeah, we can see it.
Okay, excellent. Let me just put this Zoom thing out of your vision and let's get started. Okay, so one of the things, I'd like to talk about my teaching style, and this is very informal, okay? So there's no hierarchy. I want all of you to relax, sit back, and as we go through this is going to be an interactive session. Please feel free to put in any comments in the chat if you would like me to focus on it later on. And also later on, if you have any questions, we can go through that. So let's begin. Are you sharing as well or not? Because if two people are sharing, it will not show. Okay. So I wanted to first of all break the ice and ask a question using Slido that you've gone through majority of the modules, the chunk of this course. So in your opinion, what are the key factors that make a good, effective, high standard medical education system? Let's get some feedback from you. Well done. Feedback. Do you think just the feedback, and what is WI? Sorry. High quality assessments, yes. Okay, QI, yes. Quality. What else? Come on, there are how many? 38 people. Let's get everyone, involved. Authentic curriculum, yes. Standards, great curriculum, good learning objectives. Okay, what else? Evaluation, accreditation, quality. Excellent. So we've got some great important pillars which make an effective educational program. When you say feedback, alone feedback, do you think alone feedback is sufficient? Because feedback can be feedback. It needs to be effective feedback. And now we are going to actually carry on and see what effective feedback is and how it is given. So quite a good word cloud that we have, and later on we can actually revisit it. Okay, so I believe in spiral curriculum. I hope everyone knows what a spiral curriculum is. So spiral curriculum basically means that we go back to the basic fundamentals of what has been taught beforehand. So for example, whatever has been taught in year 1, 2, or 3 of medical college should be incorporated when we are teaching, medicine, surgery, etc., the specialities. We should go back to the fundamentals so that, if the foundation is strong, the building is going to be strong. The same thing, what I've done is I've taken a few slides from what has been taught before, and I'm going to build on that. So in one of your modules, this was presented that the reason why clinical teaching might not be as good or as effective as it should be because of these points that were raised, in which there is lack of planning, no feedback, I would say no effective feedback, and poor supervision. Something else was mentioned. Let's look at that. If my slide is going to move. This was another slide that I saw where you're talking about the journey, the learner's journey, where you have a good curriculum, an effective curriculum, and the trainee or the student starts on their journey and goes through various different hurdles or milestones, milestones, I would say, rather than hurdles, and then ultimately qualifies and gets to their goal. I've added a few other things which go in that process, because on the side, you will see that there is feedback written here as well. So that means that your what you have been taught is that this is the journey and these are the important milestones. And we've added a few other things that also get incorporated into the whole process, and they make ultimately an effective educational um, system. Important thing for feedback is not just how it is given. It needs to have a system. People who are giving it need to have the appropriate training and may have certain roles that they take on. And secondly, the whole educational environment, the culture has to be a nurturing and a learning culture. And that is, not only horizontal, but it is vertical as well. And we'll come to that, what we mean by that. So the key pillars in medical education are a trained faculty, and we are on that journey through this course. A learning and teaching culture, which is evident by the keenness of everyone who is present today. Nurturing environment, that is for you to assess that whether your environments are supportive for your development, because when you develop, your students will develop. An aligned integrated curriculum. Yeah, you have mentioned about the curriculum and the type of curriculums, so it needs to be integrated and needs to be aligned with all the important aspects of a good educational system. Resourceful technology enabled system, reliable and valid assessment process. They're not just assessment process, but they need to be reliable and valid through very robust parameters, and supervision and high educational value feedback system. So I have one more slide here, sorry, going back, which is, if I can get to it. Okay, it's not coming, but anyway, we'll come to it, where I wanted to ask you, what are the systems that are present in your current day-to-day roles as an educator? So what is feedback in medical education? It is the most important, as I've emphasized before, interaction between a teacher and a learner. The learner can be the medical student, the learner can be a trainee, a junior doctor, it can be even your peers, because we all have ample of room for learning. Being a lifelong learner is the ideal thing, and there's always something that we can learn from others. So however, the process of feedback, we need to understand that there is a specific, you're trying to give specific information after a comparison has been made between the learner's observed performance against a standard. So there's got to be a standard against that performance has been, observed, and it is being given with the intent to improve the trainee's performance. So number one rule is there are no hidden agendas, and it is given with the, in a trustworthy manner and in an honest manner, with the full intention that the goal is that you need to improve the learner's performance. So aims and goals, and I saw in the very beginning you have covered this as well, that what are the aims and goals, differences between that, learning objectives, learning outcomes. So that's all very good, important aspects of the educational pedagogy which have been covered. So here the aim is that the learner gains insight on the areas where they perform well and where they lapsed, so that together a strategy can be made to narrow that gap. What is the actual and what is the desired performance. And goal is right now to enable the faculty members, yourselves, to enhance your understanding as well as the skills in giving effective feedback. So it provides an opportunity, to motivate the learners. What it should not do is that picture on the bottom right, to demotivate, to have a very negative impact, that the the motivation to learn is totally died out. So that is the student or the learners burnout. We don't want to push towards that. We want to kindle a ray that they want to learn more. So how is that given? So that is given through an effective feedback process. And in a medical education, effective feedback is descriptive. It's not evaluative. It's not an assessment that you are doing at that moment. It could follow on from an assessment, but this is like a total description. This is what you did, and this is what was observed. Yes, there is a hand that is up. Heather, you want to say something?
Dr. Haider, you're raising your hand.
I can't see anything, so I'm relying on, I've got only my screen up. So I'm relying on the coordinators to please kindly tell me. There are a few hands up.
I think there is some mistakes in it. Please go ahead.
Okay. All right. So where was I? Yeah. It should be clear, specific, and delivered in a non-judgmental manner. We'll come to that in a minute as well. So the features of effective feedback are that it connects to the trainee. Feedback should consider the trainee's individual needs and motivations. It is very important that the focus is on the needs of the trainee or the student. I'm using the trainee or the student, it's interchangeable, because I think your audience is targeted towards medical schools, but it is equally relevant to postgraduate as well. The feedback giver acknowledges and reinforces positive behavior. Very important to not just focus on or just keep going on about you didn't do this or this was not done properly. It needs to bring up the positives as well, because helps trainee get some confidence in their skills as well, and also not to destroy their self-esteem. It's very important as a individual that their whole persona that is being built as a future clinician needs to have that confidence in themselves. It involves the trainee, so it's not a one-sided. There are certain examples where in a very busy clinical scenario, you're doing a one-sided feedback mini sort of session, but we'll talk about that in a minute, how that also needs to be involving the trainee. And giving the trainee a clear role in the feedback process to help them see it as an active process. They are not the static or the dormant factor here. They need to be very much involved in it. It needs to be based on direct observation. So, there is specific information should be observed either by the feedback giver, if it is being done directly by the clinical supervisor or the clinical senior who who has taken that learner through a procedure or through a learning exercise, or that has been given to him after being seen by someone. So it is an observed thing against a given standard. It cannot be he said, she said, it's not on hearsay. And it needs to be forward-looking. So feedback should end with a plan. It's not a dead-end type of, you were terrible. I don't know how you did this surgery. This is not the good way, or this is actually not at all any way of giving any kind of remark or comment on anyone's performance. It needs to be constructive, developmental, nurturing, and focused. But sometimes it's difficult because someone might have done something totally wrong despite having been trained, and you need to say what you need to say, but it needs to still be said in a way that is constructive. So again, a slide or a infogram that I've taken from your previous educational resource, that around the curriculum you have several opportunities of assessments. So where does feedback come in? So feedback may come in any one of them. So it could be at the end of an assessment that you've done. But remember, there is something called the hidden curriculum. Yeah. So I've spoken about the spiral curriculum, which is different to what you've gone through. And I'm speaking about the hidden curriculum. So the hidden curriculum is collection of unspoken rules, expectations, behaviors that students will learn through what they observe from role models. You know, what in this day and age, unfortunately, I have to say, we don't have that many ideal role models in the senior positions in some places where the student can look up and really say that I want to be like that. You know, I want to have the personality, the behavior, the way, the interactions are between colleagues, between peer, between juniors, seniors, along with the competency. The competency is in the middle. So you could have someone who has excellent skills, but, you know, the things that are around, they need to have the standard, which may not be unsaid. And there are papers that have been published which say that maybe the hidden curriculum should not be hidden and it needs to be brought out. And then, because it will help the learners. And that is why you see things like professionalism being taught now in medical curricula. I never heard of that when I was going through medical college, because these were things that you would have either been brought up with, or you saw that in your role models around you. But in the Western, organizations, this has to be spelled out, and it has got very specific criteria that need to be followed. That actually brings me to another point, which is, the medical ethics. So does anyone know what medical ethics or, the ethical values are? Not the, I don't want you to list them. How do we define them? Because that is very important when we do the feedback. Anyone? So you have three things, okay? There are moral values, there are ethical values, and there are legal structures. Okay, legal is easy because legal means you have certain legislatures which have been accepted through the legal processes, and they are there, black and white. Moral is personal. So I might have certain moral values which are personal to me, while someone else may not have that. And the example I give is Sims, the famous surgeon gynecologist, Sims, who was in 1800, a gynecologist in America. And he was an expert in urogyne, but he performed several surgeries on Black slaves to improve his technical skills, which could be performed on other women. So that morally, it was okay for him, and it was legal at the time as well, unfortunately, but it might not be moral to other people, and it's definitely not in this day and age. So medical ethics, ethical values are what are the set of criteria which has been accepted by a body of professionals as to be followed. So the ethical values or ethical criteria that is for medical academics is our ethical structure. It may be for professions like, I don't know whether lawyers have, yeah, they must have some ethical values. Bankers may also have some ethical values. That's debatable. But the reason I bring that up is because that is very much into feedback as well. So because the hidden curriculum comes in, you are not just giving feedback on, what is the black and white curriculum learning objectives that you have taught, but sometimes you have to give difficult feedback, which might be on the hidden curriculum. So now let's come to the different ways of giving broadly speaking, there are two main ways. One is microfeedback, the other is the macro feedback. So micro is usually an informal, unplanned encounter. So for example, you've done a ward round, or you've done a teaching round with your medical students, and you've seen some patients, interesting patients, and there is something that you want to just feedback on. That, let's say you've observed a patient has got clubbed nails, or some finding, and then you would give a little bit of feedback. You will ask a question and then give feedback, and we will talk about the models there as well. Macro feedback has to be planned, and these are planned encounters, and they are less frequent, because if you have a big educational system, you may have certain milestones and timelines. For example, an appraisal review, or there is a discussion of any case-based discussion that the trainee wants to put in their portfolio. So you may have that type, or something of the hidden curriculum has happened, an event where you have to give feedback. So that has to be done in a timed and a structured way, where arrangements and a proper discussion has to happen. I would also say always document your feedbacks, because there is a lot of legality associated with this in this day and age. I don't know about your particular environment, but here students as well as trainees can take you to the court, if certain things were said and they report it, so it needs to be documented, verified. So the main structured feedback models, let's see. So the important ones I've taken out, and out of them also, I'm just going to focus on, because of time restraints, we are going to focus on the main ones. So you might have heard about the sandwich feedback model. Pendleton is the most famous one. There is this 1 minute perceptor model, the set go model, and then there's the R2C2, and then there's the agenda led model, which is the Aloba model. I'm not going to focus too much on the minor ones, the main ones. But having said that, there is all the resource I've uploaded in your module. So there's a lot more. And also in the module, you will find something very important which precedes the feedback, which is supervisors. What is supervision, educational supervision? What is the model which is present in the UK system? I've shared that. And what are the roles and criteria for educational supervisors and clinical supervisors. This can be very relevant in undergraduate. I am the personal tutor for 30 of my Imperial Medical College students. They are across the years. So there is a similar system of support, which is personal tutoring. And the personal tutor's role is very similar to the educational supervisor. So at the end, if we have time, we can touch on that as well. So the sandwich model is basically, as you understand, at the top is something that you'll say something nice, the positive things which you have observed. Then in the middle would be the areas of improvement, and then there at the bottom also there is positive feedback. But so the pros and cons I've tried to give. So the pros and cons, it's an easy one. So for beginner or novice educationists who are starting out and they want to start the process of giving this. So this is something as a good starter model. But from the learner's point of view, it's not a good model. And actually, there's many papers which discourage this. And the reason for discouraging this is because, you want to say something, and by buttering it up at the top and the bottom, sometimes the emphasis of what needed to be said in the middle gets very diluted out, right? So it needs to be important to actually make sure that the message, which is the middle part, which is where there is this lack or lapse in the performance, which needs to be corrected, that needs to be emphasized. In a way, some people say people say this is mollycoddling, you're trying to muffle up what actually needs to be said. But it can be used in not high stakes feedback. High stakes feedback is when there is something very important that needs to be, something of high significance that which has lapsed in the performance, and you have to really make that message clear. So this is the one which is used mostly, and there are some videos also in your module. Because of the time restraints, I'm not going to, take out another 10 minutes of video here. But if you, in your own time, please visit them. There's a video of demonstrating how feedback was being given in Pendleton's method. So you ask the learner what went well. So after a certain performance, so let's say a DOPS has been done, which is demonstration of a procedure or some practical task, and you ask the learner what went well. And this is a good opportunity for the learner to reflect. Reflection is very important in learning. If once a learner has this ability of two things, self-reflection and self-accountability. These are two most important things that if they are within a learner, then you think your job has been done, because they reflect how they have performed. They don't only focus on the good stuff. And even if there is good performance, they need to reflect on why is it good. Because I did A, B, and C, that is why it is good. That is also important, to consolidate what is good. And then you tell them what went well. So you can emphasize, yes, that your history taking was very structured, or your communication was very empathetic, or your dialogue with the patient was delivered in a very, or carried out in a very effective manner with timely pauses, something like that. So you're consolidating what went well, right? And maybe the learner might not have insight into what they've done well, actually, but you could say that actually you might not have noticed, but the way you gave this or performed this procedure or this task is very much aligned with how it should be, or something like that. It depends on whatever the procedure is. So, and then you ask the learner what could be improved. Now, if they are good in reflective practice, they would have said, I should have asked these questions before at the beginning, because, and later on, I didn't have time to take a full detailed history and I had to rush through. Or they can say that, yes, I could have asked this, and this, but I didn't have time, something like that. So, uh, and then once they have given their thoughts about it, and then you consolidate on things that could be improved. And here is your opportunity to give them, advice, or not advice, we are not here to give advice, because that comes under mentoring. This is also an important thing, which we may do at another time. Difference between mentoring, coaching, counseling, supervisor, tutor, all these need to be very clear, because they are different things. So we provide the information how the student can improve themselves. So this is a very important feedback model, which is often used. One other place that we use this, is, I don't know whether you have set up of simulation training. So we have high fidelity simulation where there is a sim model which can speak, and which can, you can change their various different vital sounds and parameters. And then they go through a high fidelity simulation scenario. And after that, they are taken to a debrief room, the learners. And in the debrief room, this is the model that is followed in giving them feedback. So the next model, the 5 micro skills of 1 minute perceptor model. So, or it is also known as the 5 steps model. What it basically consists of, you get a commitment. What they mean by that is that you ask a question and they commit to something. For example, you're on the bedside or you're in a clinic. So you'll say, what do you think is the diagnosis? And they'll say, I think this is endometriosis. I'm a gynecologist by background, so sorry, I'll be giving you many gynae related examples. So they may say this patient has got endometriosis. So you will then ask them, why do you say that? I mean, or what is your supporting evidence? So why do you think that? So they have to come up with, in the history, this, in the examination, this, in the investigation, this. So they're supporting evidence. Then you reinforce what was right. You correct their mistake that, no, this is not because of that, it is because this is this. And then you give them the general rule about that problem. So it is a very quick way. This is one of the micro feedback methods, and it is ideal for in a busy clinic, in a busy ward round, where you can do this. And importance or the plus point is it increases the clinical reasoning, decision making, logical thinking of the learner. So these are the soft skills, which are actually the most important skills. And if I get an opportunity, I would love to do a session on the most important competency which I feel should be in clinicians, about safety in healthcare. And maybe if we have that opportunity, I can run through those as well. So the next model is the set go model, and set go is, this is best done in a group setting. So let's say you're doing a small group a teaching scenario, and you ask either one individual, or you can do it as a group dynamic. What did you see, or what I saw? So the learner says, this is what I saw. Then you ask, what else did you see? This is what I saw along with what I saw. And then you ask them, what did you think? So whatever you saw, so patient comes in, looks very frail, the loss of you can see that they're cachectic. So the observer, the learner should see, I saw a elderly patient who seems to have lost a lot of weight. And then what else did you see? So you could say that there were signs of anemia or jaundice or something like that. What do you think? So they would reflect, or they would think about the critical thinking method, and think about what are the differentials in that particular setting. And then you say, okay, what is the goal we are trying to achieve? So the goal might be, we are trying to achieve a diagnosis. We want to come to a diagnosis. And then everyone, chips in that how best to come to, this is what we think is going on, but how do we get to that diagnosis? So it is basically, they've just given a mnemonic or a system or a structure for a group dynamics to happen in a structured way, so that, we don't go off on a tangent, because they're always in a group. There are one or two people who want to just hijack the whole discussion. And what happens is that the others suffer because of it, because you end up losing time and not getting to the bottom of what exactly we were trying to achieve. So these models help you stay within the confines of what you're trying to achieve and do the feedback. So it's very good for groups. It's good for, even peer feedback. And it's very learner driven. It's not one-sided, like the micro feedback systems where it is educator driven, but that has its own advantage of being done in certain scenarios. The R2C2 method is, it's a very American system where you build up rapport, you build up, also an understanding of how would your learner react to feedback. When you're talking to them, you kind of gauge what their reactions is going to be, and then you pitch that content of the main bulk of the content of the feedback to them, and then you coach in identifying gaps. So coaching is basically, in a nutshell, coaching is that you help the individual in coming to the solution themselves. So if someone says that, okay, I want to become, I want to improve my examination skills. So the coach will say, why do you say that? What makes you think that? How do you think you can improve of that? What options do you feel you could achieve? So the person keeps on going, answering those questions. The coach is only asking questions and helping them, learner, to come to a solution themselves. While as if you go to a mentor is someone who can advise the learner. So if I have a mentor and I will say, I really need to improve my diagnostic skills, the mentor might say, oh, this is a course and it's an excellent course. Why don't you go and do that? And that will really help you. So the advice is from mentor, not from coach. So that is a subtle difference, between these roles. So I think we are coming nearer towards the end, and I've got some interactive things to do. So in a nutshell, the three areas which are very important are the structure. So you need to have schedule the feedback session in a convenient time. So you have, the, what do you call, you have booked a certain slot, or you have saved a time where you're going to do it. And you have to have a purpose for that meeting, and you need to make that purpose clear to the learner that, we need to have some, I need to give you certain feedback, and let's do it at a certain time. So you need to make a, clear about that. The seating arrangement, like, the good method of communication is that you don't sit face to face across a table. It either is in a round table or on the side, because this means a hierarchy. We are at equal levels, although in certain, establishments, we still want to have the seniority in respect, which I also, very much, support it, that there needs to be the respect element of education giver. You might be equal as human beings, but there is a person who has got the knowledge, and he or she is making the effort of passing it on. So there needs to be that respect at all levels. But then again, there is respect for the learner as well. So this does not mean that we can say anything in any manner, because the person's respect needs to be upheld, as well as, our own. It should focus on the observed knowledge and attitudes, behaviors, the domains which we focus on in education. And then the formats of the session should be such that you're doing a joint thing, whether it is educator-led or a learner-led, and you are developing an action plan. The format is, as I said, whatever method you're taking through Pendleton's or, any of those models. And the content, basically, you need to prepare it beforehand, that what exactly is it you want to target in your feedback. It shouldn't be waffly type of feedback. It needs to be specific. And if you can narrow it down to 1, 2, 3, these are the things that were observed, and then you go through the model about how you want to take it through. Okay, so sorry, I want to go back. Now we have a few interactive slides. So I want to know what you have absorbed so far in what I've just gone through. It has been a very one-way process. So now is your opportunity. The floor is yours. What are the essential features of an effective feedback exercise? What can you remember from the last 20 minutes? Structured, very good, excellent. Non-judgmental, very nice, yes. Constructive, yes, and it should be against certain standards, very good. Constructive is being consolidated. And then there is an action plan, yeah. It is not just something for a tick box. It needs to have a purpose. Needs to be clear. Yes, not personal. Very good. Objective, timely, that is very important. Although the E is missing, but timely is very important because let's say someone has done something now and you don't give feedback until 6 months later, that mistake might be happening again and again. So it needs to be timely. Anonymous, I don't know how you can give anonymous feedback. It needs, I think it needs in the sense of this particular educational system, I think it needs to be very much specified who's giving it. Non-hierarchical, yes. Balanced approach, balance, yeah, that is why, you have those, you say good things or you highlight on what has been done. Yes. Program, so it's part of an educational program. It needs to be specific, yes. And the smart objectives like you've made, they need whatever you are saying with your action plan needs to come out as smart. Very good. Okay, now there is a quiz and I want to test something else. If you point that out. Okay, which I will tell you later on. What is the most effective way to provide feedback to medical students? Out of these, which do you think is good, is the right answer? Okay, who's giving, are you able to give feedback on this one? Is there an option?
Yes, we can choose one.
Okay, because I can't see the other side. All right. So are they not choosing? Is anyone choosing? Okay, very good. 100%. I'm an excellent educator. My students are getting 100% in my first talk. But the thing that I wanted to show you was, do you think this is a good assessment question? It's not, because the ideal way of making, because I'm saying this because you guys have done the assessment and making these questions and developing MCQs, the options should be very much plausible. So you have a stem and then the options should be very much plausible. Here, anyone can, a strategic learner or a superficial learner will be able to just guess that this is not right, this is not right, this is not right. Okay, so even if they don't know whether this is right or not, they will guess and the answer. So you're not actually making a valid assessment tool. So anyway, this was generated by AI. So this is a case that, the human interaction with AI is important. Another one. When should feedback be given? Again, let's see. Quickly. Excellent. Timely manner, ideal. Now, this is again a bad example. Why? Not only because they can suss out, but also, can you see the weight of the options? This is shorter, this is longer, this is somewhat longer. They should be equal in weight when you're making these options. So I'm with apologies to Professor, I am trespassing on other people's modules here. But I thought it's, we work in an integrated way, so any opportunity to teach is good. Why is it important to provide feedback in medical education? Again, anyone, even if they didn't know this, and this, because this is heavy, it's a long-winded, people will answer that. So excellent. I think one more only, and then we go to our final conclusion. So who should be involved? who should give feedback to students or any learner? Very good. Multiple perspectives, that is why we get the multi-source feedback. You don't have to have only clinicians or, your own specialty people. It can be anyone within your community of practice. That is another learning theory, which is Dave and Wenger's learning theory, which is of situated learning. People that are around you become your community of practice. So if you, and this community of practice can change on a day-to-day basis. Okay, Ali is entering now. Okay, let's go and congratulations. We have a winner. This has come late. Okay. Now, I have kind of concluded the important sort of, all my slides, and this is your question and answer session. So would you like to ask any questions? I can stop. Should I stop sharing so that I can interact with you guys, or you want to ask on this?
Yes, if you could please stop sharing if you have nothing more to share, so we
Yeah.
can start the
Yeah,
questions.
this is just a Slido, but I don't know. They can put the questions on in the chat. Okay, my friends. So
Is there
sorry,
anyone
that's
has a
45
question?
minutes. It is a bit tight, but I've given you an overview of feedback. And if you have any questions, obviously, if there is a workshop which is attached to this, you will be able to practice more and see the differences between carrying out different models. Yes, my friend.
Thank you, Dr. Naila, for this interesting presentation. And we have Dr. Shara raising her hand. Go ahead, Dr. Shara.
Thank you so much for this informative presentation. I have a question for peer-peer feedback. Which of these models do you think is the most effective? Or again, it depends on the situation.
For peer feedback, did you say?
Yes.
Yes. Peer feedback, if you're doing it in an informal manner. So first of all, if it is that you are the supervisor of, or at a, let's say, clinical director of a department, and one of the colleagues needs to be given feedback. So that is something that has to be done in a macro feedback setting. Okay, so you need to follow the criteria, make it clear that this feedback needs to be done, arrange a mutually convenient time, and the communication, how you lead to that, can be any of these models. The R2C2 model can also be effective. I wouldn't say Pendleton's would be here, because Pendleton is more about procedural things and tasks. When you come to these type of discussions where things can be pretty, can get pretty, how I say, warm, the discussion can become a little bit challenging. You have to maintain the dynamics, and for that, a one-to-one discussion with setting the agenda. Yeah. Now, yes, Prof. Nazar.
Thank you very much, Professor Naila, for the wonderful presentations. I would like to ask what about the feedback in non-clinical setting?
Yes.
That means that, for example, where after finishing an exam or after finishing course exams, what type of feedback is the best to suit in this way?
Yeah, so a lot of feedback, doesn't have to be in just clinical settings where there is a third party or the patient. So in non-clinical settings, for example, if you're a pathologist and someone has gone through, I am going through preparing a slide or reviewing some results or reporting a result, whatever task that is in which is involved, whichever competency that is in a learning objective in your curriculum, and that has been either performed, or you can even do a recalling of important objectives or steps in doing something, and you could put your feedback into that as well, that how would you manage, or how would you conduct this particular procedure in the non-clinical settings. Yeah.
Yes, we have a question in the chat box. I will get back to you, Dr. Shara. But we have a question in the chat box. Dr. Muhammad Nasir is saying, giving a good feedback to students is useful and essential. But in our OSCEs, we have only 5 minutes per student, and in our daily sessions, we have large number of students. These two problems seem to present a challenge. What are your thoughts regarding that?
Very good. So first of all, the OSCE, remember, you are in an assessment setting. If you're doing a mock OSCE, that is different. In a mock OSCE, they usually give 2-3 minutes at the end to give a micro feedback. But if you're doing high stakes OSCE, like the real exam, that you don't give feedback. That is a very much, you're assessing how the student has performed and you're writing the results. We do, and the OSCE system is very rigid. You just observe, the educator doesn't, or the invigilator or the assessor doesn't do anything. You're just observing and marking. That's why at Imperial we use, and I think in Royal College of Physicians, they also use the PACES system, practical assessment and practical and structural assessment, something of competencies, where you have basically at the end, so they perform a certain, they are asked to do something, so the assessor is observing, and at the end there is a kind of a viva, but that viva also, the questions are same for every single student. You cannot ask one type of question to one student and then another student at the end of the day comes and you're really tired and you start asking the really difficult question. No, the same 3-4 questions that have been set in that exam will be asked later on. So that addresses your question about the OSCE. The second thing that you mentioned was very busy clinics and how to give feedback. For that, my friend, either the system that, we have a similar situation, busy clinics can't give feedback there and then. Either what we do is that at the end of the clinic, we keep, like a half an hour, that certain students were interesting cases that they've seen or they've done, they could, you could ask them and give them feedback about that. Or there is a more protected time set separately for a teaching clinic. I don't know whether that is possible or not, but what I used to do when I was a teaching fellow many years ago, that I would, go to or identify 2 clinics, which will be my teaching clinics. So I will take out 10 patients who I will simply teach upon to my medical students, and not more than 1 or 2 students with each patient. So you have to come up with some innovative way that will address your particular, system. Shara has another question.
Yeah, my question actually might be out of the frame of the topics. What about the feedback of student to teacher and the action plan of that? Is there any specific mechanism that would be the most effective to be taken? There should be a committee in the college to assess that, or?
Yeah, so basically we have as clinicians, we have a system of appraisal. Everyone has to go through appraisal every year. And so the role of an appraiser is again different. It is not assessment. Appraisal helps your, for peers, for postgraduate doctors, the system is appraisal. So in appraisal, there is a section which is multi-source feedback, yeah, MSF. The MSF is 360. That means that you can ask students, you can ask nurses, you can ask your boss, your colleagues, anyone to give you the feedback. The MSF has got certain questions which are already embedded in them. So you need to identify the MSF. Now, some people where, on a day-to-day, like if I do teaching every day, or there is a firm, that 7-week firm rotation I have for Ops and Gynae. So at the end of that 7 weeks, I will give them feedback. That is evaluation form. So I will give them an evaluation form, like you guys will be given at the end of this teaching, that please evaluate, and there will be certain questions which you can chart out whatever you want to ask, but there are standards of evaluation questions which you can find in good educational pedagogy, that what should be asked. And you get anonymous. Best thing is that it is sent to someone, a third party, where you don't pick and choose which ones you're going to put in your portfolio, because otherwise it becomes, someone is getting 100% positive feedback, while his other poor guy who was being honest and was submitting whatever feedback he got without knowing what was in it, gets a lower percentage. So there are ways of working around it. Yeah. Any other question?
Yes, Doctor. There's one in the chat box. Professor Adil Hassan Al-Hindawi. He said, "How can we evaluate the effectiveness of our feedback?"
Okay, so effectiveness of college feedback. Is that the so either there is a body, government body, or your professional body which oversees the performance of individual medical colleges, right? Are we talking about that? So if that is the case, then each medical college will be Adil Hassan, Dr. Professor, at the college level. Okay, at college level. So, okay, at college level, you have feedback that is given by who, first of all, I need to understand. Given by? Do you want to come online,
Professor
Professor?
Adil, you could
You
unmute
can
yourself.
unmute and ask. So, I'll start answering, but if you could come on, unmute and come online, that would be excellent. We can have a dialogue. So if it is within the college and you want to know whether this is robust feedback, yeah, that means it is accurate, it is valid, it is reliable. These are the three things, when you do an assessment, these are the utility index. How do you calculate the utility index? Yes. There needs to be three important things: valid, reliable, and what did I say? Valid and reliable, as well as trustworthy. So that depends on how was this whole system, the feedback system, put in place. So that starts with were the questions developed properly? Were they were they given to the right target audience? That doesn't mean that only giving to the friends or people that will give good feedback. They were given unanimously. Were those people, was it ensured that those people could give their honest feedback, and you can make that anonymous, honest feedback, so that you get the accurate feedback that is coming? And then, was it captured in real time? Was it captured and analyzed by people in with the best way possible that you get the accurate data, and that analysis is also very robust. Okay, so the whole system you have to look at, and every milestone of that system has to be according to, you judge it according next to a standard, how it should be. If it is done according to that, then you can, say that the result is reliable. That's my answer from what I've understood your question is. Yes. Yes, there is
Yes,
a
Dr.
question.
Yaqeen.
So I wanted to ask a question building off of what Dr. Sarah had to say. So what if the feedback that students give to professors sometimes can be biased, and professors can actually, really good professors can receive biased feedback? Is there any system that can be put in to prevent that?
So why? So there's a question that comes to my mind immediately, and that is about the culture and behavioral sort of environment. Why is someone giving a biased feedback in an educational environment? Why?
I could answer that by so for example, we sometimes have professors that are really good, and they sometimes are really harsh on students, and for us to reach a certain benchmark, and sometimes it's good, it kind of fosters a very like improving environment, but other times we have professors that are more easy on students, kind of setting low benchmarks that we need to achieve, and some students actually like prefer that. So yeah, that's what I mean with the negative biased feedback.
So bias is so you mean negative feedback, because bias means
Yeah.
that they are
Yeah.
biased because let's say someone is not from your community, and that's why you're deliberately trying to bring them down. That is bias. Negative feedback on the basis of their more strict, I wouldn't say harsh, so their strict way of teaching. So, this teaching style is different. And overall, when we talk about teaching, I can remember two of my professors very clearly, okay? One was a surgical female consultant, breast cancer consultant, and I remember people going to her theaters shivering in their shoes because she would open her mouth, and if you did not hold the forceps in the right way, or cut the scissors in the right way, you would get it in front of the whole theater staff. That is a bad way of teaching, right? I can still remember her, but I don't want to be like that person. On the other hand, I remember a professor in medicine who was an absolute wonder in all, clinical judgment, personality, etc. That his ward round, teaching ward round, people would go the night before and do a ward round and know their patients, because they wanted to impress them so much on the ward round in the morning that they, did that from their own self motivation. So individuals need to be that way if they want to have appropriate feedback. But if someone is deliberately being nasty, then you have a trainee or a student, what we call trainee in difficulty. That means professionalism is lacking. Yeah, something is lacking, which is leading to that. And the system should be such, I hope that there is just one off in the whole feedback. So if you have 30 students giving 30 negative feedbacks, then there is a problem, my friend.
Yes, thank you, Dr. Naila. Any further question could be continued on the Moodle discussion forum of this module. Thank you, everyone, and thank you, Dr. Naila, for your lovely presentation, and hope to see you in the future presentations as well. Thank you, and good night, everyone.
I look forward to the next presentation, and it will be
Inshallah.
interesting.
Thank you very much, Dr. Naila. Very informative, very useful, and looking for more and more sessions with you, inshallah.
Inshallah. If Dr. Hilal, if I could ask one thing, I would like to do one on the key competencies to make a good doctor. And that would be an excellent interactive session.
Inshallah. We will
Okay.
communicate through the emails and we plan that,
Yeah.
inshallah.
Jazakallah khair.
Thank you. Thank you very much.
Okay.
Shukran jazeelan.
Shukran jazeelan. And I
Okay. So,
need to leave. And how do
مع
I
السلامة.
leave? Yes.